Welcome to everybody who has joined so far. It's a lot of attendees to filter in, so we're just going to give it another minute so that people can hopefully hear the full webinar. Okay, we will make a start as I want to make sure we have as much time as possible both to hear our speaker's presentation and to ask questions. So welcome everybody and particularly to our speaker this month, Professor Liz Hughes, to the October VAM lunchtime webinar. We're a number of webinars into the series now. If you've missed previous ones, you can access most of the recordings now online. And the slides as well. They're proving to be really popular, really valuable sessions, I think, for hearing about the latest research and analysis and thinking about the findings in a really applied real world way. So welcome to everybody. Thank you for joining us on your lunch hour. If you are not a member of the Violence, Abuse and Mental Health Network already, if you've maybe been forwarded the detail by a colleague, you can go to our website, www.vamhn.co.uk. Hopefully that will be popping up in the chat in a minute, from where you can sign up to receive our newsletter and get all of the information about what's happening in the network. We have recently expanded our social media presence, so we're not just on X anymore, we are now also on Blue Sky and LinkedIn. So if you would like to connect with us on those platforms as well, possibly friendlier places than X sometimes proves to be, then please connect with us on there. Just as a bit of housekeeping, we have this set up as a webinar rather than as a meeting, so we can't see the attendees or hear you. Hopefully you can all see and hear us on the panel. If I can ask that you please use the chat box to introduce yourselves, say hi, share resources, but if you could submit questions that you would like to ask Liz through the Q&A box, I'll be moderating those, going through them at the end of the session and putting them to Liz and reading them out on your behalf. It is my absolute pleasure to have Liz Hughes with us here today. Liz is Professor of Substance Use Research at Glasgow Caledonian University and is also visiting professor at the University of Leeds. She's a registered mental health nurse and she leads a programme of funded research related to the intersection of severe mental illness and substance use, as well as sexual health promotion and sexual violence. And she's also a co-investigator in the ESRC Centre for Vulnerability and Policing Research. If you can hear a scratching behind me and see a small child, you can see my toddler, who very much wants to come and see probably me and not all of you, if I'm honest, but hopefully she is being shepherded as we speak back to the house, but maybe she will make a cameo appearance, who knows. So I will turn my screen off. I will hand over to Liz, who will be sharing her slides. Liz will be hearing from you for about 20 to 25 minutes, and then we'll have some questions. Thank you so much for being with us here today. We're absolutely delighted to have you.
No, thank you for inviting me, Sian. It's great to be here. So thanks for the opportunity. Right. Hi, everyone. I've got some slides to show you which will give you an overview of a project that we did sort of during the kind of COVID years, as we call it, which was a funded study by the NIHR to look at the mental health and substance use needs of people who attend sexual assault referral centres. So if I can just share my screen. Here we go. Sorry, I'm used to Teams and not Zoom, so I'm a bit clunky. Okay, share. This should work in a second. If I go to full screen, and I think that's probably okay now. So I'm just going to minimize my, is that full screen? Sorry, not yet. That's it. Great. Okay, so I'm going to talk for about 20 minutes. Now, this is the culmination of quite a big study that had 5 work packages. So because of time, I'm going to try and condense it into some of the kind of main findings that I think you'll be interested in. Obviously, if you want to delve into the bigger report, the NIHR study is available and online, free online. So I will direct you to that down the line. Okay, so I'm presenting on behalf of the team. So this is a team effort. I was the chief investigator, but we had several work packages with many academics based in the team. I'd just like to acknowledge as well, before we get going, the SARCs who took part in the study, especially challenging during the pandemic. So that's very much appreciated. We also appreciate the survivors who took their time to share their experiences, complete the questionnaires. The research team who worked really hard during the pandemic. A lot of this had to pivot to online data collection. And so, you know, we kind of worked through that process. We had a group of people with lived experience who influenced this work at every step. And I particularly like to thank Faye Maxted at Survivors Trust and Conchetta Perot at Survivors Voices for their involvement and advice and help during this study. And as this is NIHR, I always have to give this disclaimer as well. The views expressed are mine and not necessarily the NIHR or Department of Health and Social Care. So, bit of background. Some of you will be fully aware of what SARCs are. Sexual assault referral centres are integrated services that provide a bespoke place to address the needs of those who've experienced a recent sexual assault. Not necessarily a recent one, but it's often the case that it is. Usually combining with a forensic examination and addressing other healthcare and support needs that could include STI tests, pregnancy tests, post-exposure prophylaxis, to prevent HIV, referrals to further healthcare and counselling. These are known as SARCs in England, are commissioned centrally by, well, certainly at the time was commissioned centrally by NHS England and delivered by a range of providers, some NHS, some private health and some private security services and some by the police, depending on how they were tendered. And they're driven by the NHS England SARC service specifications. Research has shown that sexual violence impacts significantly on physical and sexual well-being, and many people who present in the SARCs have had recent prior treatment in mental health services. However, despite this, there's very limited guidance on what the role the SARC should play in either the identification, assessment of mental health issues, substance use issues, and how care pathways could best operate so that people get the right support at the right time. In part, due to the lack of guidance, there's a range of ways in which the SARC assess and respond to it. A recent review showed limited use of standardised tools. So it was a 3-year study. We got a little extension because of COVID, but fundamentally it was a 3-year study. And these were our aims, to identify programme theories about what works for whom, for people with mental health and or drugs or alcohol needs who attend the SARC. So we conducted a review of the literature to create and establish some programme theories. We did an audit of SARCs nationally to identify specifically how they address mental health and substance use around assessment, skill mix, in-house support offers and relationships with external agencies. And then we undertook a screening study, which we call a prevalence study. It ended up not being quite what we wanted because of COVID, but we screened people who attended our SARCs that we chose to use as in our case study to assess the level of mental health and substance use needs. And then we undertook some case studies where we looked at the documentary analysis. We did some interviews and focus groups with staff, people who attended, and some of the partner agency representatives as well. And there's a final work package, which I won't talk about today because of time, which was a secondary data analysis of Chris at South London and Maudsley, and at the Kent SARC, where we were able to look at psychological therapies outcomes for people with and without sexual assault in their notes, to look at the outcomes, and that's been written up as a paper. It's also in the report if you're interested. So just a little bit about the literature review. Again, this is published, so it's in PLOS One. The reference is below if you're interested in having a look at that in more detail. So we looked at, it was very difficult to undertake this literature review because very little about specifically mental health. So we looked more broadly at the SARC literature and picked out some of the mental health stuff from within those papers. So we found that generally, in terms of identification, there was a range of ways in which mental health substance use was picked up. Mostly it was unstructured or unspecified assessment. There was some places where they were using standardized assessment tools or validated measures. Some evidence of in-house support, so immediate emotional support, which was ill-defined, some counselling offer, again, which wasn't really quantified or defined what kind of counselling it was, how it was delivered, etc. Some places were able to offer psychological intervention, and some of it was just, we didn't know what it was. And referral mostly would be signpost and refer, and some places would refer with active follow-up. And the main recommendations from stakeholder data was about, we need a more systematic, consistent way of assessing people's needs. In-house support might be useful, clearer referral pathways. SARC staff needed to be trained in mental health and substance misuse, working with people from diverse sexualities and learning disabilities as well, some of the gaps in skills and knowledge. And in the policy documents, that kind of reflects some of this as well. Okay, so in terms of the national audit, we sent out this is pre-COVID, because we started in 2019. We sent out an online questionnaire to a lot of these SARCs, and we got a 77% overall response rate, which was not bad. And it was completed by the SARC manager. And these are just some of the highlights from that. Less than 22% of a range of roles were reported to have a mental health background or mental health qualifications. The most commonly used way of identifying people's mental health was an unstructured interview. Screening tools were rarely used. Only 2 SARCs reported they had a co-located IAPT, which is increase in access to psychological therapies, known as talking therapies now. So only 6 out of those 36 said they had access to a clinical psychologist. And in terms of follow-up care and local relationships, the best relationships they reported were with rape counselling and domestic violence, and they were least satisfied with the pathways to mental health, which is not surprising given their focus. So in the prevalence study, so we got NHS ethical approval to conduct this part of the study and the interviews. We recruited survivors via SARC staff. We made telephone contact via their preferred contact details. Those who gave informed consent were emailed a link to an online server which contained several tools. So we worked with the league closely to design the safety protocol. This was done remotely. It wasn't face-to-face, which is not ideal and not what we planned. But people were told up front that when they completed the online survey, we would then log in and have a look at their responses. And if there's any safety concerns or red flags on some of the answers, then we would give them another call and check in if they were okay and what else did they need. And that did happen several times throughout the data collection. And we collected data using those tools, which is the Core 10, which is about sort of more of a kind of generic mental health assessment. The audit tool, which is alcohol problem screening tool, PTSD-5, a screening tool for post-traumatic stress, quality of life, the REQUAL, which is designed specifically for mental health populations, a drug screening tool, and the SAPAS, which is a screening for personality disorder. So what did we find? So we got 236 consent to contacts. We made contact with just over, well, about 2/3 of that. And of those 2/3, 50 consented. So we ended up with 78 people agreeing to take part. And we got a mix of genders, 91 were identified as female, 6% as male, 3 as trans or non-binary, which is not surprising if you look at the population of people who attend SARCs, it's mostly female. 73 identified as straight, 8 as gay, lesbian, 19 as bisexual. We got a mixture of ethnicities, 65% white, 13 Asian British, 13 Black Caribbean, Black British, Black African. We do have more detail on that. This is just for the presenting purposes that we've done it like that. Compared with the national SARC data, which we do have, there's a data set that collects people's demographics who attend SARCs. It's broadly representative, slightly more Black and ethnic minorities, slightly younger, but that might reflect that quite a lot of participants came from our London SARC. But in the terms of the screening, this is where it gets quite significant. 76% scored moderate to severe on psychological distress. 94% scored potentially positive for PTSD. 87% were in the clinical range for low quality of life. 45% moderate to severe health problems. 26% moderate to severe drug problems, and 63 scored positive for personality disorder. However, I will caveat that there could be some crossovers between the sort of the questions in SAPAS might actually also indicate trauma responses as well. So that's only a screening tool. It's not a diagnostic tool. Okay, so in the case studies, we had staff focus groups with the SARC staff. These were taken online during using Microsoft Teams, and they were transcribed using NVivo, and we used a realist approach to the data collection and the data analysis as well. Okay, so we did 26 interviews and focus groups with SARC staff, which was a total of 31, and 17 interviews and focus groups with staff from partner agencies. We recruited 12 people who agreed to be interviewed. That was from our pool of that 78 who took part in the screening pretty much. It was really tricky to recruit, especially remotely. We were relying on SARC staff making the first approach, but again, a lot of what they were doing had moved to remote and telephone, and they were kind of working in a way that actually thinking about the research study as well as all the complexities of working remotely and delivering a SARC service meant that actually that recruitment was much lower than we'd hoped. However, I still think it was the data that we got was pretty rich. So in terms of the themes, we kind of took a sort of a system approach when we were thinking about things that happen pre-SARC, that what happens during the attendance at the SARC, and then what happens afterwards. So we found, generally speaking, there's a need to increase awareness and access and widen diversity. So there's a lot of the staff talked to us about how they were very conscious that a lot of their attendees were female in certain age groups, then they were missing people with other characteristics. Certainly they were not doing well with recruiting, seeing men come through the door, people with learning disabilities, mental health, people from Black and ethnic minorities, sex workers, etc. And they wanted to do more outreach work to kind of reach out to some third sector agencies to encourage people to come forward as well from those underserved groups. When we talked to the service users as well, they said they hadn't heard of the SARC before they actually needed a SARC, so some awareness raising needed. There was limited formal mental health background, which often led to a lack of confidence and often experience a limited care pathway. I'm going to go through these in a little bit more detail with some quotes in a minute. There was varied practice about how psychological well-being and drug and alcohol were assessed. There was definitely heaps of evidence about trauma-informed interactions at all steps of the SARC process. particularly the SARC staff, were almost kind of living and breathing the trauma-informed approach. And this is coming through from our service user data as well, in terms of how they'd experienced the SARC, which was great. The forensic exam featured quite highly in service users' experiences and recollections, as well as a central part of one of the things that happens at the SARC. The importance of being prepped for the exam. It's a very intimate procedure. It's happening quite soon after an assault, usually, and there's a real need for some emotional support and knowing exactly what's going to happen, having someone follow you through that whole process. But the aftercare was really, really varied. Some SARCs did follow-up calls, some didn't, some just signposted and referred, and that was very much about the capacity. It wasn't that they didn't want to, it's just about capacity and how they were set up. There was some people were connected to ISVAs, which is the Independent Sexual Violence Advisor, but only if there's a criminal proceeding. So not everybody gets access to that service and support. But survivors really did follow, really valued follow-up calls from the SARCs. So I've just got a few kind of examples and quotes. I've mentioned the pre-SARC stuff, but I think the fact that the SARC staff themselves recognised that they didn't have a mental health background themselves. They came from a range of different backgrounds who worked in the SARCs as crisis workers, etc. And therefore, not knowing the system as well and not knowing who to contact when there's a concern can also lead to difficulties as well. And there's an example here where they had someone nearly 8 hours because they didn't feel it was safe to let her go, but we didn't have a safety plan in place because no one would see the patient. It was just like a hot potato until eventually, because we couldn't even get her in a car so that the police could take her to A&E safely. So in the end, we just, at least we could get her in a car and get her to A&E. So the police didn't come, the mental health service didn't come, and they just managed to get her to A&E, but it's not ideal. And anyone who's been to A&E, and if you think about the environment, that's somebody who's quite traumatized, it's really not great as well. However, the two SARCs where they have psychologists embedded as part of the team, this is incredibly useful, and was all sorts of positive things that kind of came from that, for having someone to advise, think about referrals, but also supporting staff around vicarious trauma as well. So as I said, there was evidence of trauma-informed interaction at all stages. The staff were kind, empathic, placed them in control and informed them of each step. And this is from a survivor. It gives you the sense that you've still got control, even though you've been through what you're going through, and you didn't have control when the assault took place. You can still have control after the aftermath, which I think is a really important. It's important for preventing re-traumatization, I think, and also, and I haven't got a quote here, but one of the other things that came out for me was how the survivors talked about the validation they had by talking to people at the SARCs about, it's not your fault, this happened to you, this isn't, trying to bust some of those internalized rape myths that people have, gave them a sense of empowerment and that's the kind of almost the start of their recovery as well, was having that kind of atmosphere. The forensic exam, it is what it is. There's not a lot you can do about it. It's clinical, and this quote just kind of highlights how hard and tough it is to go through it, but also how valuable it is to have that support. And this is just, it was too wide, the centre, it was too long, the hallway went on forever. I don't know what they were wearing. It was because of COVID, everything seemed really scary, but they were lovely. If it wasn't for the way they spoke, I don't think I could have managed it. So it can be hard, but also those difficulties can be mitigated. In aftercare, survivors who had experience of the in-house psychology or counselling found this really helpful. And this is back to kind of talking to someone who really gets the nature of sexual violence and understands the impact. So they were saying, they really know how to word things, and the importance of being seen as an individual, listened to, and being believed. I mean, that's really, really important. Someone said it definitely does help going to counselling that is for sexual assault and rape, because they know how to word things. You're not going to get offended. They're brilliant. They know what they're doing. And then follow-up by SARCs. Some SARCs do callbacks and follow-up after initial visits. But it's really valued where it does happen. They really like it. It says, you just know it makes it seem like they care. So it just feels like you're not out of mind as well. Access to external agencies. So many survivors had prior experience of accessing help from mental health and or drug services, and there were some really mixed views. They talked about long waiting lists after referral, after their SARC attendance, or they were offered something quite short-term and generic, but that didn't always go down too well. It felt like the person that they saw didn't really get sexual violence, and they felt like they'd been judged, and there was a lack of understanding of mental health. And here's an example. I've had talking therapy that was on the NHS, and I thought, I'm never going to go again. I didn't like her. I felt she was judging me. So I said I didn't need it and walked out. But conversely, I don't think, to be honest, I'd be here today. I wouldn't be here. I can now go out on my own and feel comfortable. But before, we've deleted the name of the services. I couldn't go out at all. So when it's helpful, it's amazing. It's life-changing, actually. But if it's not right and it doesn't work and the person doesn't understand what they've been through, it's actually counterproductive as well. Staff talked about the challenges of knowing what services to refer to, and how lack of communication and relationships, lack of mental health expertise could compound this as well. So all sorts of issues around what happens in the what happens after. And when we spoke to partner agencies, they were also kind of aware of SARCs, but had some misconceptions about what they offered too. In terms of, so one person thought that the SARCs offered long-term emotional, psychological support, and were quite surprised when actually we're saying, well, actually, no, that's not their role. And so there was a lot of misconceptions about each other's services. But just there isn't much communication or connection between the two as well. So, key messages. We did not find a consistent approach to the identification assessment of underlying or emerging mental health or drugs and alcohol problems with people who attended the SARC. So what we found basically was a lot of SARCs doing different things depending on who was there and people's interest, and whether it had funding to support psychological therapies within the service or counselling within, or whether that was something that was expected to be referred to. However, that's really worrying, because actually what we found, we corroborated the previous evidence from other studies, that people who go through the SARCs have really high needs around their mental health and substance use and issues, and actually could do with some fairly rapid support, and the sort of support that would understand what they've just experienced as well, impact and trauma informed, etc. Where SARCs had clinical psychologists, this definitely had a positive impact on processes for referral, for assessments, for decision making, for in-house provision, for team working, and to help staff with vicarious trauma as well. There were significant gaps in partner agency pathways provision for therapy and follow-on mental health and substance use support. And some people had experienced problems getting support because they were deemed too complex for talking therapies, which is the primary care mental health counselling therapy service, but not complex enough for secondary mental health care. So there was definitely a gap in the system, for sure. Many survivors and partner agents were not familiar with the local SARC or exactly what they do and what they don't do. And that's got real implications for something else I'm interested in terms of how, I suppose, as a mental health nurse, I'm particularly interested in how mental health staff facilitate disclosures of sexual assault. And if they don't know about what that pathway would look like, so that there is a local SARC and this is what they do and this is how they engage with the police, but this is the other support. If you don't know that's there, then how can you advise people who may or may not disclose sexual assault in the community or as an inpatient as well. We know that's really common in that population as an experience, sadly. SARC staff want to do more. They would love to have people with mental health / substance use expertise within their team. They want to do more outreach. The services, like everything, is getting quite stripped. So they were talking about wanting to do more outreach, but actually having to, do a lot of the face-to-face stuff and not having the time. Some of the SARCs were doing some or had been doing some work around engaging with local sex work service. University Freshers Weeks, for example, raising awareness in the student population, and thought that was really valuable. But it's difficult unless you actually got some time out of your work to do that as well. So there's definitely something to do with awareness raising as well. Okay, I'm gonna stop there, but just to flag up the references, you can have a copy of these slides. The full report, if you really want to read, it's very, very long. And we will be publishing papers from this shortly. The full report with all the quotes and this is very detailed. So we wanted to keep people's voices in it, is there in the NIHR library. And that's the reference. We've also published a few relevant papers. There's a shorter paper, which is a bit of an overview around sexual health and mental health services, call to action. And then some work from our review around mental health pathways, a documentary analysis of the SARC documents, and the review itself that I mentioned in +1 as well. So I'm going to stop talking there and I'll see if there's any questions or discussions that you'd like. I'll just unshare my screen. Come back.
Thank you, Liz, very much for an amazingly concise summary of what was a massive programme of work, and for really drawing out those key messages as well. We're really coming through so strongly that the majority of people who are presenting at SARCs have mental health or substance abuse issues. SARC staff are trauma informed, they're offering good support, but there's this problem with offering longer term follow-up and a lack of mental health background among the staff there, and really limited connections to local SARCs. There's such a lot to be thinking about there. There are questions coming through the chat. I'm just going to give people another minute or two. I wonder, while those are coming through, could you talk a little bit about what you see as the next steps for improving collaboration between SARCs and external mental health and substance use services?
Yeah, I mean, I think I think the integrated care boards could do some work around this in looking at the locality. So SARCs are pretty much based in certain patches. So there should be a SARC covering every bit. So I'll use England as an example. There should be a SARC. Any sort of service should then be able to find a SARC, put the postcode in and find which one is your SARC. However, the complication is that SARCs don't fit across the mental health kind of footprint. So I'll give you an example. West Yorkshire SARC is in Dewsbury, but serve two different mental health trusts if people were being referred. Same with Manchester. Again, they could end up with people from several different mental health trusts given their location. So one of the challenges would be to the SARC. So the SARCs have to link with more than one mental health service in their locality. So it would definitely need some sort of that. I can see where that kind of like more regional integrated care system could actually facilitate getting people around the table. I mean, I think, to be honest, there needs to be some sort of program of work that really looks at that integration. I've seen this in substance use and mental health, where the two are siloed and don't necessarily, they refer to each other, don't really know what each other's doing, and it almost needs like a summit to get everyone around the table to sort of start thinking about what needs to be done as well.
Thank you. A question, are IDFAs and ISFAs always linked to SARCs, or is there any conditions on ISFA and IDFA linkages?
you get referred to that service if you are pursuing a court case. So that's some ISVAs are co-located, others are not. And actually it's becoming quite, I think because of COVID as well, people weren't physically together anyway. So yeah, you would only get that support if you're going through the criminal justice system.
Okay.
So that's not for everybody. Or if you're thinking about it, you don't, you know.
Okay.
Yeah.
So you've got a question. Did you look into individuals who had forensic sample testing but didn't want criminal proceedings, so the samples were frozen to allow later choice? I wonder how that would link to power and control over choice and empowerment, but also confusion that the situation isn't immediately dealt with, and also whether many SARCs offer that facility.
I think it tends to be offered, even if people are reluctant to think about a criminal justice process. I think it's always offered. So the forensic exam is offered, but you don't have to have it, you know, and the forensic evidence can be just kept and stored, but it doesn't have to go any further. So there is an issue, and as some of the survivors did say, there was a bit of a reluctance to think about how far I'm going to go in this process, knowing that the conviction rate is really low.
Mm.
And there was a real, and actually we did, I mean, obviously we only had 12 survivors where we actually interviewed them. So that's not representative of everybody, but certainly I think at least one person case was dropped. So, and that's quite common really. So I think, yes, I think it's a standard practice that it's offered. If that answers, I'm not aware that it's something that would be saying, no, you can't postpone it. I think people were pretty real. I think the survivors were pretty realistic about the criminal justice system and what was possible. So I think they were pretty aware.
A couple of questions about different groups that you may have looked at in your analyses, whether you found a difference in outcomes between adults and children.
We didn't look at children.
Look at children.
Yeah, it's just adults. Yeah.
And whether there was any particular insights regarding access experiences and outcomes from SARCs regarding neurodivergent individuals, whether formally or self-diagnosed, including how SARCs consider neurodivergence and accessibility and support needs.
Yeah, so that's not something we assessed. We did have one of our survivors self-identified as neurodivergent. And I'm just trying to think, was there anything? I'm not really sure how there was anything particular that we didn't delve into that as a particular issue. But I think neurodivergence, learning disability, etc., are all things that SARCs are aware that they need more expertise on, but also thinking about how they attract people to SARCs in the first place. Because if you look at the SARC data, it's quite skewed towards young white women. And actually we know that that's not attracting a good chunk of people who could do with that valuable service as well.
Thank you. A comment that there are now even more pressures on SARC staff with UCAS accreditation demanding additional tasks to already overstretched staff. Staff having to do more with less, and patient care will be affected. It's a national issue that's been taken up with the Association of Police and Crime Commissioners and the Faculty of Forensic and Legal Medicine. So I wondered, taking that comment into account, what you think the implications of your findings are for policy changes in SARC service specifications, and particularly with regards to mental health care.
Yeah, well, if you look at the SARC specifications, they say very little about, and very little specific about what should happen and what the skill mix should look like. And we found that actually having somebody with mental health expertise as a member of the team, and that's not necessarily their job to be the mental health person, but actually just their presence, having someone in the team with that expertise really made a difference. So one of the things you could suggest is that you need someone with mental health training in that team, even if they're doing a particular job. They bring their mental health expertise into it. So that's a way of the problem with that is, I mean, I personally think if you could have the money, you'd want to invest in someone whose job it is to kind of work with the mental health and substance use issues across the attendees, and be that person who can advise on assessment, on referral, and all those things that are coming up. I'm not entirely sure that's going to actually happen in reality. But yes, certainly. And I think there needs to be standardized ways in which mental health is screened, because they can just use the tools that GPs use. They're quite quick, they're self-complete in many ways, and they would give you that would give you that score that would help you to then refer to mental health, because they understand those scores. If you cross into this threshold, then it's easier to make that referral. So I think definitely if you could get that expertise into a SARC, given the level of need, it does sort of seem to make sense. It's just often you do these kinds of studies, it's out of your hands what the policy makers do with it, really. But there is an argument there, I think.
And helpful to be able to think about in terms of supporting SARCs to speak the language of mental health services and using those already existing, well-used.
Absolutely, yeah.
And that being a benefit to the way they're able to run services.
Yeah, but I think there's gap. I mean, I think the other problem is not so much that even the SARCs, there's a gap in mental health provision for people who have had sort of trauma, interpersonal trauma, whether it's domestic violence, sexual violence. I think there is a gap, something robust, whether it should be secondary mental health or something else, but people come with quite complex needs. So they have past needs and current traumas, and there just feels like there's a bit of a gap anyway. So even if the SARCs have that expertise, they're kind of referring into a black hole for some of those people as well. So it kind of needs a system.
Yeah, rather than identifying a problem you can't then.
Yeah, exactly. So there's some slightly cruel about identifying a need and then that need can't be met locally. So
thank you. There is so much more we could talk about, but we are at the end of our sessions. I will say thank you once again to Liz Hughes for speaking to us today about the MMR study, which has given such important evidence on such a crucial topic, and to all of you who've dialed in to participate in the webinar today. We will be making the slides and the recording available. They'll be going up on our website, and we will send a link via email to everybody who signed up to the webinar, so you've got those. Our next webinar is on the 20th of November. We're staying on the topic of sexual violence with Shifra Piran, who will be talking about intimate partner sexual violence and what survivors need from health services. So please, if you haven't signed up for that already, I'm sure if you're here today, it will be of interest to you. So click back onto our website and sign up to that, and we will see you in November. But take care, everybody, and we will be in touch soon. Thank you.
bye. Thank you.